Okay, our next speaker is Michele Smith. She's an advanced care paramedic, and she'll be talking about the development and implementation of community paramedic patient and resource management systems. Michele, thanks.
Thank you very much, Gary. So presentation number 30. Let's do this, okay? So as Gary said, my name is Michele Smith. I have been with the Community Paramedic Program in Calgary since 2012, when the program was had its first inception. And I want to take a little bit of a different flavor today with our programming. This is probably one of the only real operational perspective presentations that I've seen over the last couple of days. So you get to go back to second gear, break from the data, oversaturation, just cruise control through a couple of ideas our program had, and some of the challenges and lessons that we learned with our patient and resource management as our program really rapidly grew. So just a quick review about our program. Calgary has a region that's 825 square kilometers. In our program, we have 6 response vehicles, 12 full-time staff, and we're supported with 10 casual staff members. We operate from 6 o'clock in the morning until 10 o'clock at night, and our aim is to respond to non-emergent requests for assessment, treatment, and operation. So we have a very heavy clinical intervention focus. One of the unique things about our program is we now have a dedicated patient coordinator resource and established patient coordinator center, which essentially acts as our, very similar, it's our version of a dispatch center. That office provides a private and devoted space for the dispatching of patient care events. We're partnered with over 70 continuing care sites, as well as we see patients in their own home at private residence. And last year we saw about 5,000 patient events, and our numbers continue to rise. So our focus is to provide the right care, the right time, to the right place, just like many of the other programs out there. But we quickly discovered many of our processes work, however they weren't scalable to our growth. This was identified early, and we found ourselves limited by the lack of available resources within our region. So back in 2012, we essentially did what we felt was considered a self-dispatch strategy with our genesis. You might think, why not utilize a 911 dispatch center? Calgary is one of the largest public safety answering points in Canada and answers more than 1 million emergency and non-emergency calls, answered more than 1 million non-emergency and emergency calls last year. We thought that relying or modeling the coordination of community paramedic services on systems whose focus is dispatching emergency resources might limit the effectiveness and scope of our program while contributing to the overutilization of 911 and emergency dispatch centers. We also found that traditional card system did not accurately identify the non-emergent requests, and that the non-medical dispatchers had difficulty meeting the needs of the program in the sense that they weren't sure how to process and deploy the referrals that we were receiving or the requests for service. We started with the essentially the notification, the request for service poster that you see on the right there. We at this time had 20 supported living sites, and it's a little bit small, but we had 4 specific CP phone numbers that were utilized. The CPs received phone requests for service and self-dispatch to patient care events. In theory, this was based on geography, however, that wasn't always the case. We realized almost immediately that the program was offering a service that was more than a bridge. It was providing more so a service that no one else in our area did. We were providing responsive and comprehensive care that everyone wanted a piece of. Some of the initial challenges that we had was a lack of a central intake line, as well as that dedicated resource coordinator. We were finding that the CP events occurred in isolation, and the closest resource wasn't always deployed to the event. We also determined that we were going to need some sort of primary urgent care triage criteria. However, after doing a bunch of environmental scans, we didn't really find anything that suited our needs. We wanted to make sure that our community paramedics were staying safe while they were working alone and figure out a way to track them. And we knew that in order to be able to properly intake patient referrals, we needed some sort of a referral form. Beyond that, we figured out that, again, our processes weren't scalable and we were operating beyond our daily capacity. Some of the risks throughout this process, we figured were mostly contributed to patient safety. So we were finding that there was some missed or some untimely patient care. There was incomplete follow-up care, which is a huge component of our program because we work so closely with the family physicians or the most responsible physician. And we want to make sure that we're instilling trust that we are indeed doing what we say that we're going to do as far as the care plan that we establish with them. And at this time, we were doing some paper patient care records, which we've now transferred to an ePCR. But this made it very challenging to do a transfer of care because we didn't have anyone working overnight. We didn't have anybody between the shifts that necessarily knew what happened with that patient the day before. We knew that quickly that the requesters of our service were probably going to become frustrated, and that was going to lead to more 911 events. So we needed to eliminate the choose your own adventure. With a little bit of chaos came some creativity, and we were able to formalize a central intake line, a referral form, and a patient tracking system in 2013. The request for services for our program really evolved. We were able to establish that central intake line, which is the 1855 number that you see there. It's a toll-free line that's operated through one of our local phone agencies, and it's answered daily throughout our hours of operation. And we were also able to establish a basic triage criteria to help us with the intake of patient care events and the deployment for the next available resource to respond to. We formalized the request for service into 2 pathways. So I just want to remind you that our program offers just-in-time response for same-day response, generally within 3 hours of activation, or we can accommodate requests for assessment, treatment, or intervention that will occur in the future from any of our partners. So a person can refer directly to the program by accessing that 1855 number, our central intake line, or they can use our referral form. Our referral form was electronic, so it can be emailed into our program or it can be faxed. The referral form acts essentially as a physician order that also includes follow-up care instructions to give our paramedics some discretion as well as some direction when doing their assessments and in turn creating care plans with the care team to determine what next steps are going to be. We found a great little tool called WriteFax that actually helped with the paper faxes that came in by converting them into email and coming into a group email that was monitored by our team. It started as hourly, but we learned seconds counted. Oh dear. Very basically, we had to come up with some kind of patient tracking system. And because we didn't know what we didn't know, we started with a spreadsheet. The spreadsheet at the time was because we lacked any alternative solution. It was a basic method for us to store patient information that would allow our community paramedics to attend patient care events, have a general idea of why they were going, and of course it crashed and burned. We figured out that multiple users meant multiple misses. The system relied heavily on data input, and of course data input has to be accurate and timely and reliable and saved properly. If it doesn't get saved, then we don't know. The other thing we found that most paramedics didn't know how to actually use a spreadsheet. So we had to teach our team how to use a spreadsheet as far as simple things like inputting data into a cell or adding a new line of data. We quickly realized that the program was gaining immense popularity and had a sudden increase in the number of referrals through a couple of new referral partners and new referral sources. That lack of a dedicated person to process requests for services and deploy CPV resources was really hurting us. It was resulting in delayed or interrupted delivery of care, and it really made it difficult to coordinate our resource. So we were beginning to crack, and we realized that, again, the current model wasn't keeping up. In 2014, we actually saw just over 2,900 patients, which was about a 1,400 patient event increase from 2013's data. We became more innovative and actually started doing some more creation and adopted what we thought was going to be the next best thing for our program, which was the patient coordinator role. It was a natural fit, and now it's one of the best and busiest spots on our team. So this is Claire, one of our community paramedics, who also is specialized in the role of patient coordination, and she's actually in our patient coordinator office at the moment. This is a dedicated position. Its main goal is to process and manage all of the incoming referrals, and then synchronize those referrals for the patient care event to make sure that we're as organized in our deployment as possible. This person is our primary problem solver, so we can allow our team to contact them if we're having some issues, or patients or partners can contact this person to ask some questions and get the information that they need to know. From the practitioner perspective, we were able to get back to just having dedicated, focused care. We weren't having to answer the phone at the same time as trying to do IV antibiotics. We received a little bit more administrative and clinical support from this person, because if we didn't have time or access to look something up or to find that phone number to the physician, this point of contact could help us do it. So basically our motto became just keep calm and let the patient coordinator handle it. This really turned into a huge advantage. The familiarity that this person has with program operations, policy, and constraint was just amazing. For people who are looking to refer to the program, as well as for those of us in the program who are acting to try and deliver that patient care, because they were a direct access point. The clinical knowledge and judgment that this person has advocates for patient safety and helps our patients actually navigate the healthcare system. So they may not be able to get a hold of their clinic that has their chemotherapy schedule, but we might be able to look it up for them on the weekend or after hours. It's been an effective and efficient scheduling of patient care based on referral requests. It's also allowed for valuable communication and continuity of care. So although we fax our patient care records to any member of the healthcare team that we know is involved with that patient after we have a visit, sometimes there's questions. Sometimes they don't know exactly what that means on a patient care record, or sometimes it doesn't arrive, so they're looking for it and they want to know what happened with their patient. And now they can just call this number and we can get that information to them as quickly as possible. But probably most importantly, the patient coordinator advantage really allows our team to remain patient focused. Most recently, we adopted and implemented a tool in 2015 that allowed our region, that our region had already been using, which was scheduling software. It's been a huge improvement for our team. This is the only data I have, I promise. So in 2014, like I said, we saw just over 2,900 patients, and in 2015, that number nearly doubled. We figure in about October of 2014, we reached our max capacity as far as being able to see about 4 to 5 patients per practitioner per day. And we wanted to figure out how are we going to optimally schedule this resource. We were lucky enough to find a tool in our region that's called eClinibase Scheduler, or eScheduler for short. It's linked to a database called Clinibase, which is essentially the source of truth for the patient identification and encounter management in all acute care sites in the zone, as well as community health centers. eScheduler was meant for clinics in acute care sites or in community health centers. However, this amazing team was able to adapt their programming so that we could use it in our very unique community paramedic environment. It was also equipped with custom reporting tools to assist our QA strategists with evaluating clinical outcome measures. And it allowed for us to really nail down what the roles and responsibilities of our patient coordinator was going to be. And we were able to actually generate a manual based on this tool. The benefits of eClinibase really, we've been so lucky. So we're now able to waitlist requests for service when we have reached capacity. We are a program that takes appointments in the future, and sometimes while we're waiting to see that patient, they're admitted to hospital. They have a specialist appointment that comes up, or they have been able to get in to see their own family physician, so we can make room for other patients that are waiting to utilize our program. We've been able to efficiently manage the patient load and program capacity, which at this point we still consider ourselves to be at capacity daily. We've tried to figure out how to best optimize the CP resource, and by being able to map it out through that eScheduler program, we think we're getting closer and closer to that every day. It has a real-time link to acute care sites, which has been a huge time saver for us. So although the patient or their family members may forget to call and tell us that they're on the way to the hospital, or if it's a little bit more urgent or emergent of a situation and EMS has seen them, as soon as they are triaged by someone at the acute care site, we see that they've checked into an acute care facility, and we know that we don't have to spend time driving to their home to go and see them today. However, we do follow up with whoever referred them to our program to see if there's any changes to their care plan after they're discharged. And this real-time update about event status has helped us with some of our practitioner safety. So as soon as our community paramedics arrive at the patient's home, they have the ability to say that they've attended the event. Once they've attended the event on eScheduler, the appointment actually changes color, so we can see that they're actually there. Probably one of the biggest benefits of eScheduler or eClinibase is that we've been able to work with the patient around the scheduling that we have to do. So we're not telling them when we have to show up unless it's a time-sensitive sort of thing. We're telling them that we can work with their medical needs, we can work around their chemotherapy or their specialty appointments, that we don't want to be there the same time as home care because then we're either wasting home care's time or ours. And that we want to make considerations for their family commitments. We're not just seeing elderly patients that are at home waiting for us to get there. We're seeing young moms who have to get their kids to school and then have to get off to chemotherapy after that. So we're really trying with this tool to make sure that we're keeping a focus on improving their quality of life by being able to see the full schedule. Oh, sorry. So some of the current challenges that we're facing now. We want to continue to use our resource efficiently and safely. So we're looking at implementing a tracking tool to help us determine where our practitioners are. But we imagine in the future that someone's going to probably have to monitor that for us. We know that we would like to at some point pursue EMS crew referrals, and we need to try and find some capacity to do that. The program also continues to be in great demand, and we need to start anticipating how long it's going to be before we potentially outgrow this model. And the last thing is the patient coordinator position is the busiest by far because they're the quarterback of our team. We need to find a way to give them some administration support and give them some capacity back so that they can continue doing what they do best, which is doing the intake and the contact with our actual partners. So some of the key objectives for CP resource management systems is establish that central intake line. Don't let them choose their own adventure. Do the request for service model that allows easy and reliable access to your program, whatever that may look like. Find a patient tracking system to coordinate efforts much earlier than we did, and determine what a sustainable capacity is going to be for you and your program. We wouldn't be a program, I don't think, right now if we didn't have the time and effort dedicated to the coordination of resources. So find that quarterback, find the person that can be your deployment manager and your intake manager and your administrator all at the same time, and then employ a scheduling tool that's going to allow you to maximize your day so that you, like us, can see as many patients as possible. Thank you.
Jackie, would you stand up in the back there for a minute? So the Saskatchewan College of Paramedics printed the programs for us, and I forgot to acknowledge them. And Jackie's the executive director, so Jackie, thank you very much. These are very, very nice. So we're at number 31, and we have two presenters for the Seoul Paramedic Collaborative Emergency Center project, Steve Skorodko and Kayla Burkilo. How did I do? All right. Welcome.
Well, thanks. I know it's been a very long 2 days, and we're holding you from the last session to get out and enjoy the beautiful weather. It's outside, so we'll get through this. And I know it's been a long day. There's a lot of long faces out there. But again, my name is Steve Skredko. I'm an advanced care paramedic, and we hold a contract with the Saskatoon Regional Health Authority to provide service for Waka and surrounding area, and therefore also putting with a contract the paramedics that are in this. And it's been an exciting process and change for us over that last number of years to roll from just emergency services to doing this dual role purpose. So again, we're going to split some of the stuff up here, and we'll go from there.
Right, can you hear me okay? So again, my name's Kayla Burkilo. I'm the manager for the Waka Primary Health and Collaborative Emergency Center. And it's truly a pleasure to be here today and co-presenting with Steve. And I heard someone reference yesterday to the importance between participating and engaging. And I'm a farm girl, so I really like the reference to the pig and the chicken and the egg and the bacon. But this is truly a great example of EMS engagement. So and the health region really couldn't ask for a better partnership than Waka EMS. So that's the front of our building. As you may have heard yesterday, there's 13 health regions within Saskatchewan. We are part of the Saskatoon Health Region. We're the only operating CEC within the Saskatoon Health Region, and there are 5 CECs operating within the province. And we were the 4th one to get established. You can change the slide. So I'm going to go over just a little bit of history. So in 2011, the Saskatoon Health Region changed the designation of the Waka Hospital to a health center. So this meant a reduction of services to outpatient care. So basically there was an RN during the day and lab and x-ray from 8 till noon. And really this was because of the inability to recruit physicians to the community. So with that limited service, there was a large push between the community and the health region. Another partnership emerged in really trying to recruit doctors to the community. That partnership was successful, and there was always a primary health care clinic, but it kind of came and went depending on the doctors and what services were provided. And so that settled out and became fully staffed once again. And so at the time that was all going on, the primary health care clinic was municipally owned and operated. And so with the closure or the conversion of the hospital to the health center, this did bring an opportunity to bring all those different health groups and those health services together in one facility. So the healthcare clinic, although municipally owned and operated, was moved into the health center, as well as home care. And then eventually the clinic transitioned into the health region in October of 2014. So today the clinic operates with 2 full-time permanent doctors, another full-time position which is made up of 3 different part-time physicians, and 1 full-time nurse practitioner. And we do staff a satellite clinic 4 days a week besides the Waka clinic, which is 5 days a week, plus some extended hours. And it's important to note that in the recruitment process, having no on-call has become very important for our community, that we're actually being approached by physicians looking at us because there is no on-call responsibility. So what the health center provides during the day, and this is how it looks today, is lab and x-ray, home care, occupational and physical therapy, live well, chronic disease management, mental health and addiction services, population and public health, as well as the clinic. And then we do have some private services of an eye doctor, massage therapy, and a chiropractor. So then in October of 2013, the Ministry of Health announced that a collaborative emergency center would be established in Waka. So this announcement was truly embraced by the community, and the health region does have a commitment to the communities that they're involved with to really engage them and to have discussions with them on what services might look like within a community. So with this announcement, they went to the community health councils. So this is sort of a process that was already established with the health region, and it has membership of town, of the surrounding RMs, the local pharmacy, there's a concerned citizens group, there's a seniors group, so it's quite a diverse group and offers a lot of different opinions and ideas. So through that health council, the community was engaged, and then a specific CEC development committee was formed. And that just gives you an example of all the different representation that was on that committee.
And just another point to add on that as well is that the community consultation was a huge part of this. I think without the community involvement and driving a lot of this, we wouldn't have been as successful and moving the model forward. Every one of our community groups pushed very hard to make this move forward and to get that. So that's just kind of a little representation of where we are located in the province. We're 90 kilometers outside of Saskatoon, and we're kind of an hour from everything else around us. We do have one other small hospital that we'll speak a little bit more about, which is 40 kilometers across on a not great highway, but that's where we're partnering with for our physicians. And we do have quite a large catchment area that, you know, people are there. The other unique piece to us as well is we have a lake that's right next to us that has 700 cabins on it. So in the summertime, our population does grow by quite a bit, which is a challenge for ourselves, and we do see that grow in the summertime as well for us. So when we started down this and had the community consultations as well, we looked at facility needs, which was unique to the other collaborative emergency centers that are here in the province of Saskatchewan. All the other collaborative emergency centers are attached to a long-term care facility, and our current long-term care facility didn't have any room to attach us to that, which was one of the considerations. We had what used to be our hospital, so we had the space there. The physicians were already there. It was a great space for us to use. It was the old emergency department. Everything else was there for us to come in and just basically move in and start right away. So there was no renovations needed. There was no other changes that were needed to do that. We looked at what our equipment needs were. They were fairly minimal. A lot of the stuff was already supplied there because it was an emergency department. There was a little bit of upgrades to things like Life Pack 15, a few other minor things that were needed to upgrade as well when it came to some of that. One of the biggest challenges and one of our uniquenesses of our model is the staffing requirements. We looked at a number of other ways, but because of our situation of being an hour away from Saskatoon and Prince Albert, we currently employ 11 casual advanced care paramedics, which helps us fill into our funding model. I don't think if we had that availability of those casual paramedics, that we would have the same success as somewhere else, because it does bring kind of some of the experience of the advanced care paramedic and the experience that they are all usually fairly seasoned paramedics as well. Gives them a little bit of a downtime, and it is a little bit of a change in what their normal kind of day is. And they do find that it is a good kind of switching gears for them, if you want to call that. We also addressed some of the training needs, which included, again, because we were a contracted operation, to integrate with the health region, that we had some of their training to bridge some of those gaps, so that we were all speaking the same language when it came to things like total lift movement, some of those other programs that were within the Saskatoon Health Region. So that was also something that we looked at when we did that. And then we also went into looking at what a communication strategy was going to be, not only within the Saskatoon Health Region, but in the community. And it's still something that we're working on today, which we talk a little bit about later. So the other things that we looked at was we wanted to provide same day or next day medical appointments for primary health. That was one of our goals, is that local residents were really feeling a gap when some of the physicians had left, that they couldn't get an appointment to see that primary health care team. to get the care that they needed. So that was our biggest goal, was to be able to try and arrange that. And it was really important that we had a mix of the physicians and the nurse practitioner during the day and the paramedics at night that came together working on that. The extended hours for primary health care were an important point too, which Kayla will talk about in a little bit, as well as our goal originally was 24/7 access, but that's now since changed, since we've kind of been at it for over 18 months now and looked at what the numbers have actually shown us out of that. And access, equipment, training, and other features, we kind of had looked at some standards that were originally done in Nova Scotia and some of the standards that were done here in the province as well when we implemented as well to fit into that criteria of a collaborative emergency center.
And so through all of that consultation, all that consideration, we came up with a staged approach. And stage 1 was implemented in May of 2014. So as I mentioned, the regular clinic hours were from Monday to Friday, 8 a.m. till 4. And so we added some extended hours on a Wednesday evening until 8 p.m. and Saturdays from 8 a.m. till 12 p.m. And then we moved into stage 2 in September of 2014. And so this provided access to the center from 8 a.m. till midnight, 7 days a week. So this staff's a paramedic team. There's always an advanced care paramedic along with an intermediate or primary care paramedic. And so what happens when somebody walks into the facility during the paramedic hours? They come in, the paramedics take them into a treatment room, they do an assessment, and then there is a consultation by phone to somebody in Rostern. So we use the on-call physicians in Rostern. And so through that consultation, through that phone call, then a patient goes one of 3 routes. They're either treated and released, treated and returned, or treated and transferred. So treated and released, they're treated, they're sent home. There's no need for further follow-up. If it's treat and return, they still get to go home, but they're made an appointment that next day to see one of the daytime providers. And then treat and transfer, if they do need a higher level of care, then they're transferred out, usually to Rostern, and Steve will talk to some of the stats around this, and usually by private vehicle.
And again, with the consultation with the physician, regardless of whether that patient's a CTAS 1 or a CTAS 5, we have a consultation always with the physician that's over in Rostern. It's been a great growth experience for the physicians as well as our paramedics, that they're not only seeing them, because we do rotate the paramedics out into ambulance still, and that's our primary transport hospital. So they get that face-to-face, but they also get to grow that little bit more knowledge base with them working in the facility as well. And if at any point, any one of the group, whether the paramedic, the physician, or the patient are uncomfortable with what is being recommended, any one of those can stop the line, and absolutely a transport over to Rostern Hospital or to the appropriate center is given. So
we are going to show you a little bit of our data. So this first slide just shows you the number of visits that we've seen since opening in September of 2014. And we share data on a quarterly basis, so the most recent or last 2 months aren't up there. But we've seen 594 patients. And so if you were to average this out, it equals to about 1 per night, which is what all of the other CECs in the province and Nova Scotia, I think, have been seeing. And so we consistently meet that target and sometimes over exceed that. And if I had May up here, you would actually be seeing that we averaged over 2. So that was a really good month for us. And this slide just shows you a comparison. I said there was 5 CECs. Spiritwood is the 5th one, but they're 2 new. We don't have their data to share with you yet. But Kenora, Shaunavon, and Maidstone have been operating, and that just gives you a representation of how many visits are going to each site, and it's fairly equal, but Shaunavon does see a little bit more.
So a lot of our patients are really low acuity. There's not a whole lot of the real urgent patients that walk through our doors. You can see over the last, since we started, only 13 have been CTAS 2. Everything else has been CTAS 3 and down. Lots of dressing changes, lots of other things that come through there. And we're seeing, mainly abdominal pain, earaches, lacerations, localized swelling, upper extremities and cough. And actually, I think the big thing that's changed and our biggest service provided is dressing changes. We're doing sometimes 3 dressing changes a day for patients. It suits their lifestyle. They're at work during the day. We're there from 4 to midnight, which is convenient for them. They can't make it during the day. So we're seeing more and more dressing changes, suture removals, just regular things. We've also just brought on IV antibiotics first dose for patients now, which is a huge win for us. And then we can also do any subsequent dosing. So if somebody needs to get follow-up antibiotics Q8 hours, we're able to do that and facilitate that in the facility if they're uncomfortable with doing it at home on their own. As well as we had a small pilot project with flu vaccination last year, which we're really looking to grow this year. Previously, public health has come in and done mass clinics, but now that our pharmacists in the community as well as our paramedics can do it, they're looking at maybe redeploying some of those resources to some of their other areas. So we're excited to see what this next flu season brings for us in regards in growing that. And again, it's convenient. Our paramedics are there from 4 to midnight. Again, people are working. Sometimes they work in Saskatoon or Prince Albert as well, and they commute home. Well, it's not convenient for them to come home from work, pick up their kids, and then go back to the city in order to access some of those services. So if we can give it to them right in the community in what works in their schedule, and again, any one of our patients, it's a walk-in appointment. They can access us at any time. The whole goal of the building was, and our plan was to have the building accessible from 8 a.m. to midnight, 7 days a week. The type of person that you might see or the practitioner might change depending on the time of day, but you could access some form of healthcare from 8 a.m. to midnight, 7 days a week, which prior to us starting this wasn't happening. It was all over the place in regards to times and what people could access for their services that they needed in the community. Also, just speaking to our treat and our 3 pathways that we have, the treat and release, treat and return, and treat and transfer. We're keeping 62% of our patients in the community, so they're not having to, actually it's closer to 80% if you combine the treat and release and the treat and return. Only 21% of our patients that we have to transfer out at some point. And sometimes that transfer out isn't always necessarily because they need to go to that. They may be from Saskatoon and they're going to decide to seek the additional services that they require in Saskatoon, which I'll talk a little bit about coming here. But we're doing a really good job of keeping the residents in the community and reducing their travel time, because like I said, they're traveling sometimes an hour to the next service for any of their services that they need for healthcare. So on the transfer piece of that alone, 94% of our patients are going to Rostron, so that's showing us, again, that low acuity, that CTAS 3, 4, and 5. It's a regional hospital. We're not sending them to the tertiary Saskatoon that, they don't need the trauma center, they don't need the cath lab, they don't need the resources of a large city center, which, again, the problems that sometimes come up with ER waits and offload delays for ambulances. And out of these total patients that we're transferring, as you can see, we've only sent 3 to Rostron, 2 to City Hospital in Saskatoon, 1 to St. Paul's Hospital, and that 1 to Melfort actually went on their own. And that's a lot of, out of that 94%, only about 10 of those, less than 10% is transferred by ambulance. Most of those transfers are by private vehicle. So when we talk transfers, we're not talking EMS transfers, we're just transferring them over by some other means. The actual acuity level and the ones that we're transferring by EMS are very, very low. So we're doing a good job of trying to keep them in the local area and trying to reduce the pressure on Saskatoon itself. And again, just a little bit of our demographics. We're seeing a lot of our local people, so Waka and Cudworth, which are only 10 miles apart or 16 kilometers. That's our biggest group. And then you can see also then our kind of other is our visitors, which is the Saskatoon and then out of the area. We do, again, because of the lake population in the summer, see quite a large number of out of area people, and it's for a lot of minor things, lots of cuts, lacerations. It's a lake, right? Everyone's at lake having fun, doing their recreational activities around there at that time. So, just some of our uniques. This is again the paramedic model. We're the only model in Canada that staffs an advanced care paramedic and a primary care paramedic. Every other system has some combination of RN paramedic combination, whether it be primary care paramedic or advanced care paramedic. So we're pretty unique in that aspect and pretty lucky. Again, our location affords us to have the advanced care paramedic and the primary care paramedic work as a team. It's been a really good partnership of those two working together, and we found that we're meeting a lot of the community needs with those two level of practitioners right now. Our hours, like I said, the goal was from 8 a.m. to midnight, 7 days a week. Our hours for the collaborative emergency center itself change a little bit from time to time. Typically during the week, it's from 4 to midnight. On Saturdays, we're there from noon to midnight because there's a primary health clinic on Saturday mornings, as well as we're there all day Sundays. So from 8 a.m. to midnight, there's no primary health, which is our one gap that we're kind of identifying, that we can't meet that same day or next day appointments in that model.
Any stat holidays, then the paramedics are staffed from 8 a.m. till midnight as well.
Again, our location, the proximity to Saskatoon, Prince Albert, we're that hour around, we have quite a large catchment area. The roster and connection has been huge for us. All the other collaborative emergency centers in the province of Saskatchewan go through the STARS physicians. We have that direct link to roster, and so not only does it build the relationships with our paramedics and the physicians, it's also built that they know that patient's coming, and we've had that conversation already, and so they have a heads up as to what that patient coming in is going to look like, and they know that pre-stuff has already been kind of done and started for them on that way. Electronic medical record, or EMR, has been another huge step which we've just implemented February. And it allows not only the paramedics to enter that data into the EMR and the primary healthcare team to see stuff, but vice versa. The primary healthcare team enters that, the paramedic can go in, look through the record and see what was done prior in that day or in the prior weeks that patient has. So it gives a better overall picture as to what's actually happening with this patient and what the go-forward plan might be with the patient. There might be some notes or other data on there that says, well, this patient is going towards this or what we need to do. They were there a week ago for antibiotics, but that hasn't been resolving it, so how can we maybe manage that or move that forward in an example for them? The other piece that's been an advantage to us, and you kind of saw Doctor in a Box, we've kind of got a little bit easier system of that. It's video, and it's like a FaceTime, but it's a secure computer-to-computer interface, which allows the physicians to actually lay eyes on the patient. So the greatest example of this is in skin conditions. You can describe a rash how many ways until you actually see it and know what that looks like. It's really hard to describe sometimes, so that's been a key piece for us as well, and access to that so that they can actually lay eyes, and that's reduced some of our transports as well because they can actually physically see the patient. So.
Okay, so we're nearing the end here, so some future considerations. So after a year of operation, the ministry did ask us to undertake a review. So that was a pretty intense review was undertaken, and these are just a couple of the points that came out of that. So further development of a communication strategy, we did a launch and a kickoff, but there's always a continuous need for promotion, for education of the people, just understanding, what can they come to the CEC for. So.
And I think we're also seeing that we're still not capturing all of our patients. We did a review of the data that looked that a lot of our patients were still going over to roster, and there were that CTAS 3, 4, 5 that could have still benefited. They just didn't know what services they could receive in the facility. So we still are planning to kind of grow that education piece of the public as a general piece.
And then, we're considering some model enhancements, and so we're working with the community once again to figure out, are there still some community needs that aren't being met, and is there a way that we can fulfill that through the resources that we have in place? So whether it's an expansion of additional evening with the primary health clinic, or extension of the lab and x-ray, or whether the paramedics become somehow involved in that. And oh, is that me? Increasing the scope. And then we're also exploring some education and informational sessions. So we'll see what comes out of that work and how what this model may change or look like in the future. So.
Just some of the other things that we're looking for: increased scope of practice for our paramedics. One of the biggest things that we're missing right now is suturing. We know that that's a little ways down the road for us, but it's something right now we're just using gluing or steri strips to kind of take care of some of that stuff. And there is definitely a need for that. That's just one example of some of the things that we're using, as well as just expanding some of the other educational pieces and time that we have. Again, there is a little bit of downtime with us seeing 1 to 2 patients every night. So we're looking at some other things like women's health clinics, larger growth of education pieces that we can add into the building that our paramedics are there, and maybe supporting other groups coming in like public health or other practitioners that we might be able to see and support in those evening hours that, again, trying to bring the healthcare to the patient so that, again, they're not focused in on Saskatoon, and that we're trying to keep people in their home community and surrounding area. So I think it's been a huge benefit, and there's a lot of growth yet still to happen with the project, and we're excited to keep moving it forward and growing that from there. So that was the opening night of our Collaborative Emergency Center, and a bunch of our paramedics, and Kayla and Lori, which is one of our project managers, has helped with implementation of it, and we're pretty excited to keep moving that project forward. So again, Gary's going to come up and yank us off stage here right away, but because we are the last group and everyone's going to probably get up and run out the door, 2 minutes for questions, I think, if that's doable. Was there any questions? Not seeing any questions. All right. Thank you, everyone.
thank
Thanks
you.
for a conference. Enjoy the Saskatoon, and we'll see you later.
All right. Well, I want to say thanks to everybody. We're just going to do a couple of cleanup things before we go. I have to say thanks to a few people who make my life a lot easier. Anne and Emma, who volunteered their time to do the live streaming for us. Thank you very much. We have posted all of the presentations on the IRCP website. If you go to ircp.info, click on meetings, and then 2016, you'll see those all on the left side. Once Anne's husband gets done segmenting our videos into individual clips, we'll post those on the right side. So the PDFs on the left, the videos on the right. The PDFs are already there. Mary, there's Mary. Oh, Mary and Peter O'Mara are also two other people that are really important in making my life work well, so thank you for that. We've got the two microphones live. I'm wondering if anybody has any general questions for any of the people that spoke today or other people that did presentations that you'd like to make. And then I've got one more closing thing I'd like to do. No? Okay. Dave, would you grab that microphone? So I'd like to ask again, we did this at the beginning, but of the people that are here, how many of you are going to try to get to the UK on February 9th and 10th? Awesome. We'll do the call for proposals for those sessions sometime soon, probably August or September-ish. And so we're looking forward to another great program. What I'd like to do now is start with Dave, and we're just going to pass that one microphone around the room. So from person to person to person. I'd just like you each to say one thing that you learned while you were here these last 2 days that you didn't know before you came. So Dave, you can start. Put you on the spot.
Well, that works. Is this on? I think the one thing I picked up is no matter where we're from or whatever color uniform we wear or whatever, I think our experiences are pretty near identical. We all serve people, and I think they have real similar needs no matter where they come from.
And please stick to one thing because we got a lot of people to get through.
Thanks. More of a comment. It's nice to see a group of people that are very patient-focused, people-focused. A lot of healthcare and a lot of different departments are moving much more towards financial motivations, and this group is much more patient-focused. So that's been a nice change of pace. So
they have us on a great start. That's the kind of thing we want to hear.
I think it's been really great to see how, for Canadians, we actually are a lot more similar in our programs than I initially thought. I thought that our program aligned in a lot of different ways with the Saskatoon programs as well as the Nova Scotia and Ontario programs that we got to hear about.
I learned that Ryan doesn't know how to pick footwear and needs to work on that because I'm not going to piggyback him.
I learned that we're all chasing data and trying to translate it in a way that resonates with the business we're trying to do.
I've been blown away by the range of services that are being provided. It's an amazing collection, and perhaps we should at some point think of a way of collating that information to share wider.
Mary's working on that.
The range of collaboration that seems to be out there is a lot bigger than I think most people think.
For me, it's been, I think the capacity that there's felt is within our paramedics, and how we then try and get that capacity out of those people. Our paramedic on the road will probably deny that they have got the capacity, but I think it's just the extra skills we're going to give to try and get that capacity out.
From Western Australia, I'd like to thank the Canadians and everybody here for your hospitality and the way you show your friendliness to us, the visitors here. Thank you.
From Western Australia, yes, thanks Canadians, it's been great. The one thing that I've picked up is we're all struggling with the emerging PTSD issue. It's an international thing.
I'm with David. I think the range of services that's offered in some services just blown me away.
Yeah, I think one of the things I took from this was the moving from a case and incidents towards more patient-focused recording of data.
This is my first visit to the IRCP, and I'm just so impressed with the advancements that paramedicine has done in a relatively young profession. They're already growing into like a mature status and looking for new ways to get out there and impact healthcare and integrate themselves